Well, thank you guys for joining. My name is Cameron. This is Kaley. She is my mentor. We did some work together, making a nutritional website, and we did some blogs together. But I just wanted to bring her here today because she knows about pediatrics and clinical work and some of the similar interests that I share. So, without further ado, Miss Kaley.
Yeah, thank you for that introduction. So I got to do some mentor work like Cameron mentioned with her. So that was a lot of fun. My first time being a mentor, so I enjoyed it. We got to do I kind of wanted to focus on doing more with technology and nutrition. So, especially with COVID, and I guess you could say not even COVID, but COVID kind of pushed us more towards the telehealth world. But, you know, medicine was already starting to go a little bit that way with a lot of increased telehealth visits and you know, more people online and wanting kind of those remote visits for easier access and things like that. So with that, I kind of wanted to work on getting more evidence-based information out there and more accessible to people. So we kind of started working on some of that to get that moving forward. But like Cameron said, yeah, my name is Kaley Brooks. I am currently a clinical pediatric dietitian, and I work at Nemours Children's Hospital here in Orlando, Florida. There's also a Nemours Children's Hospital. I don't know if you all are familiar with that specific hospital, but there's one in Delaware as well. So it's only pediatrics, two locations. The Orlando location's a bit newer, whereas the Delaware location's been around for, I want to say, at least 30 years. I'd have to look at the exact date of when they opened, but they've been all around for a bit longer. So they're kind of like our mother hospital, if you will, and we're kind of the little sister, newer hospital. But so I figured I didn't prepare a PowerPoint today. I figured I'd just kind of talk to you guys. But I figured I'd kind of start with kind of what brought me to nutrition and dietetics, and you know, how where I did my undergrad and kind of how I got to where I am currently. So basically, nutrition was always just a really strong interest of mine ever since, I would say, at least like middle school or so. I was always, you know, my friends were always wanting to buy like Cosmo magazine and all these, you know, like fashion forward magazines. And I was the one buying like Women's Health and always wanting to really learn about, you know, what foods can I eat to make me healthier, make me feel better, minimize disease, you know, things like that. So I would say that's kind of where it started for me. And then it really just snowballed when in high school I played sports. So I guess always wanting to be my best and feel my best for that, to perform better. And then, you know, going into college, I knew I wanted to do something in the health field. I wasn't quite sure. I hadn't pinpointed nutrition quite yet. I had interest in being a dentist, maybe. I had interest in being a physician assistant or like nurse practitioner at one point. But then I really just kind of honed in on nutrition when I took that first nutrition class. My first original major was exercise science. And we had to take nutrition and physiology, I think it was. And I really just kind of grasped onto nutrition and loved it. And you know, I knew obviously what a nutritionist was. I don't know that I knew exactly what a dietitian was. So I learned all about that, and I was like, I can really see myself doing that. And I've really never looked back since. I immediately changed my major to dietetics, and have kind of never looked back. And I went to the Florida State University in Tallahassee, Florida, for my undergrad. And I graduated in 2012. And then from there, I started work pretty soon after graduating at the WIC program. I don't know if y'all are familiar with that or know anybody that works there, or I know a lot of dietitians kind of go that route. There's kind of those two options where you can go like the DICUS route and kind of go through the matching process, or you can do like WIC or a job that maybe has a built-in internship that you can apply for. So I ended up doing both. I did send out a DICUS application as well, and I got matched to one that it was kind of like my bottom choice, and I was kind of not sure. And I ended up just going to work with WIC because I figured I'd get a lot of experience. I've always really, really liked kids. So I figured if I did want to pursue a career in pediatrics in the future, that might be a good place to start, because I'd be around lots of new moms and little babies all the way up to age 5. So I did that, and I really enjoyed it. It was very eye-opening, not only in the nutrition aspect, but just the community in general. I learned a lot about people in general. So I really enjoyed that. And I actually worked there for 5 years. I started as a nutrition educator, which for those of you that aren't familiar with WIC is kind of the entry level kind of nutrition position. You don't have to be an RD for that. And you just talk to moms and the little ones about good nutrition and what to eat, how to start solids, how to eat well when you're pregnant, that kind of thing. So I did that. And then I actually did do my internship through WIC as well. And I requested to have a pediatric emphasis. So a lot of my rotations were kind of tailored to that. I did some rotations at All Children's in Tampa, like St. Petersburg area, which was really, really great. And a couple other pediatric rotations. I did one at an elementary school, and working with like the school food program, and a couple of other things there. And then after that, I actually became a supervisor for WIC and did that for a couple of years, while also finishing up my internship and becoming an RD. And then shortly after that, I decided I kind of wanted to do a little bit more clinical work, still within pediatrics though. So my professional experience thus far has really been mostly in pediatrics. I don't have a ton of experience in adult care. Obviously, when we get our RD, we have to have a certain amount of hours in adult clinical care. So I did do some in my internship, but I haven't really done much in my professional career thus far. So I then took a job with Nemours Children's Hospital, which is where I'm at now. And I kind of bounce around a lot in the hospital, but I mostly do acute care in the ICU. I do a little bit of NICU every now and then with our really little preemie babies. And I also do a little bit of outpatient, and Cam knows about this because I do some work in the diabetes clinic. and I work with, type 1, type 2 families. And I do that outpatient clinic once a week. So that's kind of, I do a little bit of inpatient and outpatient, mostly inpatient acute care, but then I do enjoy working with diabetes and families and all the education that is involved with that clinic. So I like to kind of keep that one. I also was on a research study that was funded by the NIH, and that was through Nemours as well. And that was looking at type 1 diabetes and we called it a transdisciplinary care approach. So it was largely behavioral health and nutrition focused, because our principal researcher on the team felt that there was a need in the community to show that children with type 1 diabetes, this one was type 1 specific, don't get enough behavioral health care as well as nutrition involvement. So it was trying to prove that if a child has better access to that their clinical outcomes would improve overall. So including their mental health, their A1C, their compliance with medications, all of that would improve. So all of our data is being analyzed now. That study just wrapped up about, I think it was about 8 or 9 months ago now. So hopefully I can keep Cameron. I'll send her the results of that study, but hopefully that'll be published soon, and we'll be able to, move forward with more research and more nutrition involvement with type 1 diabetes. So I really, really enjoyed that. Would love to do more research if the opportunity arises. So that's something that's pretty cool about working in clinical work, is that these research opportunities do arise. And, us as dietitians are typically approached by physicians or other researchers that maybe need a dietitian on their study, things like that. So it's kind of cool to be able to be a part of something like that, and especially for the future, and always promoting nutrition, and definitely something that I enjoyed a lot. So that's kind of me in a nutshell, and kind of how I got where I got. Oh, I did forget a large chunk. I also did do my master's at University of North Florida in Jacksonville, and I graduated not too long ago with that. It's been about 2 years now. And I did that in clinical nutrition and dietetics. And it was mostly, there was some in person, but it was mostly distance masters. And I do know that they have a combined master's and internship program, which I've had a couple of friends go through and recently become RDs that way. But I definitely recommend it if any of you are interested in obtaining your master's. It's a good, definitely a good program to go through. So that's kind of me. So I kind of wanted to open up for any questions. If you guys have any questions about, how I got to be where I am, or any questions about things that I may see, in the ICU or patients, things like that. Would love to answer any questions that you guys may have.
I have one.
Sure.
I'm also interested in pediatrics. specifically with eating disorders, but because you did such a specific internship, do you regret doing a specific one and not doing a general one to kind of see your other options? Or because you were so like predetermined before your internship, like I want to work with kids, that doing a specific internship really, really helped you out in terms of like getting jobs later on?
Yeah, so a couple of things I have to say about that. So I actually had an interest in eating disorders as well. And I did do some work in my undergrad with an eating disorders facility. It was residential. And I did work there for a couple of months. Very, very cool field to be a part of, especially if you're interested in that behavioral health aspect of nutrition. And that, the behavioral, I always talk about this because I have a strong passion for behavioral health as well, because I feel it's so important for every aspect of the medical field, just because most of us are trying to elicit some form of change, whether that's a diet change or new education, if a patient's going to be on a new renal diet or something like that, any kind of change is involved with behavioral health, right? So because a change is typically a behavior. So I always, say you can tell people to eat veggies all day long, but they're, the process of them actually doing that is a whole nother story. And so I like to work really closely with our behavioral health team, because I feel like a lot of times I need to call them in and kind of have them help me dig down and figure out, what someone's motivations are for change. But having said that, I personally don't regret doing a specific internship. And I'll tell you why. So and this may have changed. I don't know for sure, but I know when I went through my internship, you had to have a certain amount of hours kind of in each discipline. So you had to have a certain amount in clinical, a certain amount in community, a certain amount in food service to be eligible to take your RD exam. And so most internships will only allow you a certain amount of like specialized hours, if you will. So you still are going to be required to do adult clinical to some degree. I think you have to meet at least, I want to say it's like 120 hours or something. I could be wrong. It might have changed, but and then you could potentially add on some rotations to meet that final hour requirement. And those specialized hours could be in pediatrics or eating disorders. If whatever internship you apply to has the ability for you to go out and seek those, or if maybe they already have them built in or have connections for those specific things. But yeah, so for me, I don't regret it because I still got a lot of general adult care and things like that. And then I feel lucky or kind of privileged to have been able to get some specialized work as well. So I feel like I kind of got the best of both worlds, because I got to specialize in something. I do want to say that I did some extra hours over what's required, but I didn't mind because I really wanted to get that pediatric experience. And it also was really great too, because it gave me some more insight into, is this what I want to do with my career? And it kind of solidified that for me. I really enjoyed it, especially my all children's rotation in Tampa at the pediatric hospital. It really was like kind of an epiphany moment for me, where I was like, okay, I think this is what I want to do and what I'm going to pursue. So hope that answers your question.
Thank you. Yes, it does.
I have a quick question.
Yeah.
So how is your daily schedule at the new hospital, like wearing so many hats and seeing so many children in so many different age groups? Like, what's your autonomy like, and like what's your day-to-day like?
Yeah, great question. So It varies a lot. And I like how you said wearing different hats, because that is absolutely true, especially in pediatrics and in a pediatric hospital, because you're dealing with such variability. Like a newborn baby is very different than an 18-year-old, so not only nutritionally, but just, from every aspect. I mean, they're, eating foods that are way different. They're in school versus not in school. They may or may not be out of their parents' home, so there's a lot of differences there. But so my day typically looks like, I usually get to the hospital around 8 or so in the morning. And I usually go through, all of the patients that I have on my floor, and kind of, we call it screening, but we kind of just go through and look for certain nutrition risk factors. In the ICU, it's a little different, because there's a lot of, how can I say this? Like, especially in pediatrics, we have a lot of complex kids, like say children with cerebral palsy that have feeding tubes, and they end up getting admitted into the hospital frequently, if you will. So a lot of the kids that I have in the ICU now, I'm very familiar with. So I don't necessarily have to spend a lot of time going through their charts and things like that. But when there's a new admission, which, we still get a lot of those, our ICU is relatively small. It's a 18-bed ICU. So I would say at any given time, a good 4 of those are kids that I'm very familiar with. And then the others are kind of ones that may come and not stay quite as long. So typically, I start my day with going through all the patients, looking at labs and weights and things like that. If there's been changes, maybe if I made a formula change or something the day prior, I want to look through the nurse's notes and see if she made any comments about, the patient tolerated the new formula, they were vomiting, they had diarrhea, blah, blah, blah. So just so I'm not kind of blindsided for rounds in the morning. So I usually spend about an hour or so going through all of that. And then I will say that if you're out on vacation or something like that, you typically have to catch up, kind of like you're like, okay, all these patients now are new. So my 1 hour screening is now probably going to be like 2 to 3 hours. So I'm going to have to start my day a bit earlier. But rounds typically start at 9 or 9:30 in the morning. And they involve myself, the dietitian. They're multidisciplinary rounds that occur every single day in the ICU. So it's myself, there's a pharmacist, there's usually 2 attending physicians, 1 or 2 nurse practitioners, respiratory therapy is there. If there's a specialty that's also following in addition to the regular hospital attending physician, like neurology or something like that, they'll try to attend rounds as well. We also are now considered a teaching hospital. So we have a lot of residents and med students that are on rounds. So imagine it's quite a large group. Usually there's anywhere between 8 to 15 providers, I would say, including all of us, that kind of go room to room. So in the ICU, it's also very, very detailed. We go through everything like with a fine-tooth comb every day. So rounding can take like anywhere from 2 to 4 hours, depending on how many patients we have and how complex they are. So usually from 9 to about noon, I'm tied up in rounds, and I really try to not have other things interrupt rounds, because you really, it's like a little summary every day of the patient, and you've got everybody's attention, you've got the family there usually. So if you need to make changes and things like that, you can do it right then, which is really nice. So then after that, my afternoon is usually meeting with families individually. You know, if somebody in rounds was like, hey, Kaley, you know, I heard about this new organic specialty tube feeding formula, and I want to talk to you about maybe transitioning my child to that. Could you stop by later? And, you know, that kind of thing. So usually for an hour or two in the afternoon, I'm kind of meeting with families individually, addressing any questions or concerns that came up during rounds. And then the rest of my day is usually charting, like just documenting everything that went on throughout the day. And so that's a pretty typical ICU day. An outpatient day looks very different. Clinic is a lot more, I guess you could say, like planned. Like you have patients that are scheduled typically like 2 to 3 months out, so you know what your schedule looks like. And so diabetes clinic is very fast paced, but you know, it's kind of the same thing where we try to do multidisciplinary as often as possible. So in diabetes clinic, they come to clinic and then they usually see the endocrinologist, the dietitian at least once a year, sometimes more, and then the social worker and the certified diabetes educator nurse as well. So we kind of filter through you know, when they need to be seen, making sure that each patient is seen at least once a year for nutrition. And usually in one of those clinics, it's just an afternoon. So clinic starts at 1, and typically our last patient is around 4. And they're every 30 minutes or so. And then there's usually two different providers in one clinic. So as the dietitian, there's 2 doctors, but only 1 dietitian. So sometimes I may have as many as like 12 patients in that short time, which is usually not always doable. So I'll kind of have to prioritize and see who really needs to be seen versus someone that maybe was just seen last time they were here. Usually they come every 3 months or so to see the endocrinologist. So if they had just been seen by a dietitian last visit, then I may not see them the very next visit unless something comes up or they have a specific question. So that's kind of how my days look.
That's crazy.
Yeah, it's a lot. It's a very fast pace, but you know, I really enjoy it. I know people that are interested in clinical typically like enjoy a faster pace, and it's definitely lives up to that stereotype, especially in pediatrics.
Yes. Well, thank you.
Yeah.
Hi, I'm Olivia. I kind of relate to you. Whenever I came to LSU, I was originally pre-med and then bounced around to pre-PA and all of the things. Eventually landed on dietetics, and I have a huge interest in like my main goal is to be a pediatric dietitian as well, like in the ICU. So target audience reached.
Yeah, that's awesome.
I was just wondering if you could talk about like specific cases that you see a lot, anything like that. I know HIPAA is like, you know, you can't say too much, but
yeah,
just curious.
Yeah, absolutely. So in the ICU, we see a lot of crazy stuff. So I will say that pediatrics specifically is interesting because you see a lot of rare disorders and diseases that you may not see in adult care. So we see a lot of like rare genetic conditions. We see a lot of like Down syndrome, cerebral palsy. What else do we see a lot of? a lot of like short gut, bowel disorders, Crohn's disease, trying to think. A lot, I would say, honestly, a lot of it is like some sort of usually genetic something or other that has all kind of symptomology that requires like a wheelchair, limited mobility, a lot of trachs, a lot of feeding tubes, that kind of stuff. We do have a hematology oncology unit as well. So I see a lot of those patients in the ICU only when they're like septic, unfortunately. So like usually they're on the hemonc floor unless things aren't going so great. They may get transferred to us. And then if they do get transferred to us, then usually again they're in sepsis, and they are probably hemodynamically unstable. So we typically don't feed them for some time. We will usually start TPN, that kind of thing. So we do a lot of TPN in the ICU, especially babies that come in. They don't have the glycogen stores that an older child or an adult has. So to prevent like tissue breakdown and stunting of growth and that kind of thing, we typically start TPN pretty quickly on the little babies. So a lot of TPN, a lot of feeding tubes. So I'm constantly calculating on the fly. That's one thing that I really enjoy about rounds. It's a little daunting at first, I will say, but the physicians really start to look to you to give your recommendations. And they admit, they're like, hey, I had like one class in nutrition when I was a med student, and I just have no idea what formula to pick for this kid. There's so many out there, especially now. So they'll really look to the dietitian and they'll say, hey, like what formula, what rate, when should I start? How much should I start? All of that stuff. So we do a lot of that. We do a lot of like specialized recipes. So say there's like maybe a kid in the ICU that has renal disease, or even is like having an acute kidney issue where we need to limit protein or limit fluid, things like that. So a lot of times we'll pick like a generic formula, like say Pediatric or something like that. And then we'll have to add in like modulars, like things to boost up their fat or their protein specifically or fiber specifically, but we only have a certain volume we can work with. So it's a lot of like playing with numbers. I will say that you have to probably like math if you want to be in the ICU, because it's a lot of quick calculations. And the physicians will frequently say, hey, I want to give this kid 100 calories per kilogram. How much do I need to give them? So like you kind of need to like be able to do that quickly, especially if it's an infant formula. Those are totally different ball game, calorie and nutrient wise, than adult and older pediatric formulas. So I would say that's another huge thing with pediatrics specifically, is all the different formulas out there. There's a lot for adult care too, but I would say there's even more for kids, and a lot of more like variety, like so many different things for certain disease states. And then there's like hypoallergenic and hydrolyzed and elemental and milk-free, dairy-free, soy-free, like all of these things. So it's that's something that I do a lot of too.
That's so interesting. Thank you so much.
Yeah, you're welcome. I'm so glad that you have an interest in it. And we are actually hiring right now at Nemours. So just something for future, if you all are interested. I feel like pediatric hospitals are, at least the couple that are in my area have been growing just exponentially. And, they're always putting blasts out. Hey, if you know anybody good that's interested in pediatrics, that, even if they're a brand new dietitian, we're open to training them and things like that. So lots and lots of opportunity out there. It's just growing like crazy.
That's good to hear. I'm a junior
Yeah.
now, so I got a little bit of time, but I will be looking soon.
Yeah, that's awesome. Anybody else have any questions?
I just took some notes while you were talking, just because I learned a lot about you just now, which is awesome. I didn't know quite a few things, but I did learn that you've done a lot. I feel like you're very well-rounded. Like, you've done research, community, clinical, and then you said that your interest kind of started with sports. So I was wondering, like, were you ever interested in doing like sports?
Yeah, that was actually an interest of mine for a little while, and it's not that it changed. I mean, I still have an interest in it. I just haven't really pursued much in it yet. There's always that open window, but yeah, I have a good friend that actually was on the swim team for Alabama, and I worked with her at WIC. Actually, she's a dietitian now, and she's kind of now into that kind of sports nutrition world. So that's a whole nother opportunity for dietitians that is huge. I mean, I know a lot of professional sports teams now even hire their own dietitian, which is really cool. He could be, if you're really into a certain sport or pro sports or things like that, that could be a huge opportunity. Yeah, I haven't really done much with it. But yeah, it's definitely an interest. I love to read like new research and stuff on nutrition and sports when I see it come through, that they're doing new studies and stuff on supplements. And I'll tell you, in probably just about any field in nutrition and dietetics, you're gonna get questions on supplements. Everybody always wants to know, should I take this? Should I take that? So that's definitely not just sports specific. That's something that you'll get from friends and family too. I can tell you, everybody always asks those questions.
Well, another question, just because right now I know a lot of my classmates and me are in our senior year, and we are taking nutrition and disease, and we're learning about a lot of the clinical aspects. And something that we've come across is just like, what do you use a lot? Do you use ADIME or SOAP notes or both?
So when I worked at WIC, we used the SOAP note format, but that was a couple years ago now. And in the hospital setting, we do more of an ADIME for sure, but it's also kind of tailored. So there's a bunch of different electronic medical record systems out there. We use Epic in specific. So we've kind of built over the years, just based on what we all have come together, like a group consensus of what we want to have as like staples in our notes, but it does pretty much follow an ADIME format. But we basically have like tailored the ADIME to be what we want it to be, I guess you could say, but it's just even more detailed. It definitely has every section that ADIME would have. It just has like a couple subsections that we've added. I would say that SOAP note is a little bit more like outdated, if you will, than ADIME. ADIME's a lot more inclusive, has a lot more details, and is more clinical minded than SOAP notes are.
Okay, cool. Yeah, we've been learning about that, obviously since the get-go.
Yes.
But we've been doing both, so we want to make sure that we know how to do it either way. And
Mhm.
with that being said, there's a lot of different formulas that we use, and do y'all stick to certain ones, or do you just know all of them, how to use all of them,
Like as far as like energy requirements and things like that.
like that?
So we use, let me see if I have it right here. I don't think I do. We use a pocket guide. Have you guys ever had to get like clinical dietitian pocket guide books or textbooks for any of your classes?
Yes, and I think that Miss Motley, our professor,
Understood.
actually talks about that one a lot. So if you know
Okay.
the same one.
Yeah. So the one that we use at the hospital is it's from Texas Children's Hospital. It's like this big, pretty thick, and it's got a ton of formulas and resources, formula information. So it's not like you have to have all this stuff in your head, right? You kind of have that to take with you and make notes in and things like that. Um, I also have like formulas that I use a lot in the ICU. There's probably a solid 10 or so that I use all the time. So I have their nutritional information. It's called like a healthcare provider fact sheet. A lot of the manufacturers bring them to the hospitals for us to have, and they have them on their website as well. But I screenshot all of that, and I have their apps too, so that I can access this information quickly, especially in rounds like someone, maybe a physician will say, hey, we really need to limit this patient's calcium. Is there a formula that has less calcium than what we're giving? And then that way I can kind of look through and compare all of our formulas and things like that. So we really use that resource for the formulas. But basic knowledge, I would say for pediatrics, we use a lot of like DRI. So rather than doing like, I don't know, like if you guys do Mifflin, St.
Yeah.
George, or like Harris Benedict, I think it is
We
the
use
other
a
one.
little bit of all of them too.
Yeah. So a lot of it is a little trial and error in learning your patient too. Especially with pediatrics, because they're all so different. If I could have like an indirect calorimetry machine to take with me to each room, I would just love it, because a lot of these really complex kids, I swear they gain weight from breathing in air a lot of the time. So it's, some of them I have on like 300 calories a day, which seems wild, but they still grow and gain weight on that. So it's really, really interesting to tailor these energy needs. But yeah, we use a lot of basal metabolic rates. We use a lot of DRIs, and then we do Schofield a lot. I don't know if you've heard of that one,
I think so.
or Schofield. Some people say it differently. That one is kind of like a Mifflin for pediatrics that I would say it's kind of like a Mifflin where you find basal metabolic and then you add on like activity and stress factors. So that's another one that we use frequently. And then we have one that is for like non-ambulatory. So we call that either non-ambulatory needs or cerebral palsy. Even if they don't have CP, we sometimes will use that if they present like a patient that would have CP, like they're, spasticity, or they have limited mobility, or they're in a wheelchair, things like that.
Okay,
Yeah.
awesome. So it's pretty much like learn as you go and see what works best.
Yeah, absolutely. And then, I don't want you guys to feel stressed about that, because you have your pocket guide. Usually the facility that you work at will provide it for you. when you get hired and when you're training, you can, I mean, when I got hired at Nemours, I read that thing back to front, because I was like, I want to know all this information. And you also, can carry it around. I mean, I carried mine around with me for probably the first year or two. But now I don't carry it as much because I do it so frequently. But yeah, it's a super good resource to have.
Cool. I was wondering, how do you feel? Because when I'm in class, I love what I learned. I just have a passion for nutrition, obviously, like I really enjoy it, but I'm very like antsy to get hands-on experience. I feel like I'm just like a hands-on kind of person. Do you feel like you learned a lot, like just going to your internship and you got like more like confidence in your ability and stuff?
Absolutely. So I am a huge believer in experience as an education tool, because it's just, to me, it's so important. And I mean, you can learn all day from the textbook, but real life isn't textbook, right? So like, it's just very, very different when you actually get out there and, you're making clinical decisions on your own. You have your textbooks and your knowledge to kind of guide you, but ultimately your clinical judgment is what's gonna, kind of prevail, I would say. So, yeah, I definitely, it really helps to put like A to B, like putting everything together, is what that hands-on experience is really, really good for. I feel like I could kind of visualize, like when you do case studies and things like that in class, it's like you can kind of visualize how things would go in a hospital setting, but actually doing it is a different story. And it'll really, really, really build up your confidence once you get to start shadowing in your internship. And then usually towards the end of your internship, at least in your clinical rotation, they will give you your own patients and things like that.
Okay, awesome. Well, do you have any tips or tricks for us, since a lot of us are about to go into internships? Or any words of encouragement, anything?
Yeah, I mean, it is fast paced and it is a lot. But if you all have made it this far, you can absolutely get through it. And it'll be so rewarding at the end, I promise. So just hang in there and, and really enjoy, like try to enjoy it, because it's kind of a cool thing that, our profession does in a way. At first I was like, man, this is kind of frustrating, to have, for everyone to have to go through this. I know I want to do clinical and blah, 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 but it's really nice to be able to get that opportunity to kind of get a little taste of each aspect of dietetics. Because you just don't know until you've tried something. So to be able to do something for like a week and then get to do something else and see it all, I think is really kind of a cool thing. So try to enjoy that. And if any of you guys want to reach out to me ever, if you have clinical questions or anything like that, I can give you my contact info as well. So, but yeah, I'm so excited for you guys. It's such a fun time.
Thank you so much. Has brought a lot of insight to the clinical world, and I appreciate your time.
Absolutely. Yeah, I'm glad I could join.
Thank you.
Good luck to you all.
Yes, thank you.
So much.
Thank you so much.
You're welcome.
If y'all want to hang back for a second, I just have a few announcements after she is done.
I will text you, Kaley, and just keep you updated about everything that goes on with my internship. So
yes, please do. And I will send you just my I think you have my personal email, but I can give you that one and my work one, and feel free to share it in case anyone wants to reach out.
Awesome. Thank you so much.
Right. You're welcome. Nice to meet you all.
Bye.
Bye.
All right. Real quick, I'm just gonna share I know there's not that many people here, but the National Nutrition Month calendar. If I can do it. Yeah, okay. All right, so this is everything that's going on this month. I think Dr. McKinley added a few things today, like some webinars or something. But we're gonna have a table in Free Speech Alley tomorrow. I think they still need a few volunteers for that. So if y'all are free, I think it's between 11:30 and 12:30. Try to like sign up and just go at least for like 30 minutes. I know seniors have class, so that takes out a good chunk of people, but if anybody can do that, that would be greatly appreciated. And then the fridge clean out for the Baton Rouge Community Fridge. Don't forget you can drop stuff off to Dr. McKinley's office or outside of the food lab. And is that ending this week, Cameron?
No, I think we're gonna end it at the very end of the month, and then I'm
Okay.
gonna bring everything on the 1st of April.
Okay, yeah, so y'all can drop stuff off all month. And then you can also, so 5 items is 1 point. And then if you Venmo $5, that's a point too. And then this is just, if y'all want to screenshot this, if you haven't yet, but it's in the Google folder. And I think at the beginning, Dr. McKinley sent the link to the folder so y'all can keep up to date with it. But other than that, I think that's it. So
Yep.
y'all are good to
And
go.
also the produce event, if anybody wants to come with, let me know.
Oh yeah.
It's in Zachary, so the only thing is like you'd have to have a car, but if you want to just like ride along with me, that's fine too.
Yes. That's this
With
weekend
Miss
coming?
Motley.
Next weekend.
Next weekend.
Next weekend, yeah.
Alright.
All right. Well, I think that's it. Thank y'all for coming. If y'all have any questions, y'all can email me, but I think we're good to go.